Hello and welcome to In Time TV's On the Edge, Conversations in Internal Medicine. This is another special report. I'm Dr. Jonas Moses. With me today, special correspondent to On the Edge, Doron Feinsilber. Dr. Doron Feinsilber is a resident in internal medicine. And I do want to point out that while the main theme of our conversation today is RSD, CRPS, that is Reflex Sympathetic Dystrophy, Complex Regional Pain Syndrome, we are going to finish up a little conversation that we had last time talking about endocrinology, and I did want to pick up the conversation there, Doron. Unfortunately, we don't have any slides for this week, but that's all right.
That's
we
fine.
will, if you close your eyes and imagine what we were talking about last week.
Yeah, well, I believe last week we finished off in the show talking about pheochromocytomas and very rare endocrine disorders. And part of the reason why I wanted to mention it on the show, and just to sort of reiterate everything, is that some of the medications that we are using for pheochromocytomas tie in directly to what we're talking about today.
Indeed.
So that's an interesting spin-off to take on these things. For people to recap on what we talked about last time, the pheochromocytoma was an adrenal issue. It's a type of tumor that's going to constantly be secreting catecholamines, norepinephrine, epinephrine, or they call them metanephrines because those are the byproducts of these substances that can cause a feeling of like impending doom in the patient, massive peripheral vasoconstriction. So a lot of these patients will end up having hypertensive urgency and emergencies. They'll have subarachnoid hemorrhages, in which case where the actual bridging veins in the subdural region of the brain can cause to have a lot of hematomas, things like that, or berry aneurysms are the big thing right now, and that's also something that ties into what we're discussing in terms of pain syndromes. But what's interesting is that those types of malignancies are treated very well with reversible and irreversible alpha blockers. So phentolamine, for example, is a selective irreversible alpha blocker. And then a lot of times, even perioperatively, a lot of surgeons are going to be using phenoxybenzamine, which is a reversible alpha blocker, before a surgery. Because what's going to happen is that when you go in and resect this part of the adrenal gland during surgery, the danger you're going to have is that you may actually have a spill-off of all these catecholamines into the bloodstream, and can be very dangerous in the operating room. So a lot of times they'll use that, but you're...
Let me ask you a question here. You mentioned reversible versus irreversible. Can you explain in a little more detail what you mean by that?
Well, phentolamine, that being an irreversible alpha antagonist, means that once it binds, it stays.
And continues to do...
And it's more of a permanent block or a blockade.
All right.
Why is that important? Because if you have a reversible blockade, that means that later on this patient can be managed conservatively. Let's say if the patient is not normally hypertensive, then you don't want to have this person with a constant alpha blockade. You want to have only a temporary fix to what's an organic problem that's being corrected by the surgery. And that's actually why you want to use those types of medications.
Good.
So that's, yeah.
I wanted to ask you one of the other things that we did not get to in our conversation last week in talking about endocrine disorders like acromegaly and other disorders of pituitary. For instance, you and I had a conversation about empty sella phenomenon, and there's a cup at the base of the brain, a bony cup, and the pituitary gland sits inside this cup, and this is the sella.
Sella turcica is the proper name.
Sella turcica.
Right.
And I have had patients in the past, when I was in clinical ophthalmology, I've had patients with empty sella syndrome, and there are associated visual field defects that go along with this, and we were talking about these, the hemianopsia.
You're right.
Perhaps talk a little bit about these kinds of disorders and about acromegaly.
Well, acromegaly is essentially where you have a constant endogenous oversecretion of growth hormone, and that's again going to come from the pituitary gland.
And we see what kinds of defects because they're clear.
The interesting thing about acromegaly is, depending on the specific patient population, we can actually tell what the symptoms are going to be. If it's pre-puberty, then what's going to happen is that the growth plate is going to expand, You'll have, that giganticism that, like we talked about, at some point where, you have a guy who's going to be like 7 feet tall and, with thick lips and things like that.
And a bony brow ridge and
Yes.
large joints.
Yes, but what's going to happen that if it's after the closing of the epiphyseal plates, and just to kind of reiterate what that means, is that after you've reached a certain level, let's say like age of 18, 19, 20, when your growth plates basically fuse shut, and if you have more growth hormone, now it's not going to affect the plates. You're not actually going to become taller, but you're actually going to go the other way. So instead of going vertical, you're going to go horizontal. And so that means your fingers can be very thick. And what the most dangerous part of all is that you will get a massive cardiomegaly from this. So basically you're going to have what's called a restrictive cardiomyopathy. That's very dangerous.
It's a thickening of the tissue?
It's a thickening, right. Because remember, there's 3 different types of cardiomyopathies. You have a dilated cardiomyopathy, which is what patients usually experience when they have chemotherapy. You have a restrictive type, which I spoke about just now. People have like hemochromatosis, like iron storage diseases, things like that. And now, so if you have acromegaly, that can also cause that type of cardiomegaly. And the last one is called HOCM, or hypertrophic cardiomyopathy, and that's people who usually have a genetic predisposition with the myrosin gene, and that's going to cause the heart to be markedly dilated like that, or more concentrically dilated. So, so now with acromegaly, that's a big danger. Now you're talking about visual field deficits. If you're actually at the level of the sella turcica, or the optic chiasm is another area that's referred to.
The pituitary is directly beneath the optic chiasm.
Yeah, you will actually develop a visual field defect called a bitemporal hemianopsia. And I can even kind of diagram out, even on a sheet of paper, what this looks like. And maybe we can even get the camera to zoom in on this a little bit. But if this is your visual field, and let's see if I can show this up to the camera.
If you can hold this up.
You got that? Yeah. So if you look at that, left eye and the right eye, you see that the areas that I made a little bit of line at, those are going to be areas where you won't be able to see.
So your peripheral visual field on both sides is going to be absent.
Correct. Right. So that's actually what that can cause. Anything that goes beyond the point of the optic chiasm is going to cause a contralateral hemianopsia, meaning that if you have a lesion on the left side, it's going to show up on the right. If it's on the right, that's going to show up on the left. And so, those are all the different types of pituitary disorders that can cause that type of condition. So people have hyperprolactinemia, like what we said with acromegaly, things like that.
Actually, I think we're going to cut to a commercial break. We'll be right back. Stay with us. This is On the Edge, Conversations in Internal Medicine. I'm Dr. Jonas Moses. With me this hour, Dr. Doron Feinsilber. We'll be right back. Stay tuned.